Welcome to the Frontier AETC Project Echo. I'm Kent Unruh, and I'd like to turn it over to Dr. Brian Wood, our medical director, to introduce our guest.
I'd really like to thank Dr. Ann Collier for doing a talk for us today. Dr. Collier is a professor of medicine here in the Division of Allergy and Infectious Disease and director of the AIDS Clinical Trials Group. She's been doing HIV care since the very early days of the epidemic, and we're very happy to have her. Ann, thank you.
Okay, well, thank you. It's great to be here. What I'm going to attempt to talk about today are some of the more important of the topics related to antiretroviral therapy that were presented at CROI. As you probably know, it's a very large meeting. There are lots of sessions, and what I have done is to pick out a few of the more high-profile studies that raise a variety of issues related to antiretroviral therapy. The big good news is that the majority of HIV-infected patients in care in the United States in recent years do extremely well and achieve extremely high rates of viral suppression. These are data adopted from the plenary session that Joe Aaron of UNC presented. These are data from over a cohort of over 100,000 patients in care in the United States at multiple sites around the country. And what you can see is among those who are retained in care, prescribed antiretroviral therapy, actually over 90% appear to be virologically suppressed. So this is much, much better than the cascade of care that you may have seen from years ago in the US, but it certainly doesn't represent everyone, and that's really the issue that was identified and highlighted at many other presentations, that individuals are being left behind, and we need to do more and be creative about how to do better for the individuals who are not currently successful with our strategies. So we're going to look at 3 studies today that deal with issues trying to improve care and antiretroviral therapy for individuals who have challenges. Some of the potential solutions and ones that we're going to touch on include use of longer-acting antiretroviral agents, parenteral agents perhaps for those who have challenges with daily oral therapy, looking at social support or novel incentives to reach individuals who themselves are not highly motivated to stay in care, and one study looking at a potentially less toxic drug. So the first study we're going to look at is a study called Latte-2. Latte-1 was a study that was actually published recently this fall, and this is a follow-on study looking at long-acting parenteral therapy as a strategy for maintenance therapy. So for those of you who are not familiar with the drugs that this study used, cabotegravir is a novel integrase inhibitor that's an analog of dolutegravir. There are 2 formulations of this, an oral formulation, which was studied in the previous study I mentioned, which suggested that this oral agent, which has a half-life of over 40 hours, showed efficacy and safety in combination with rilpivirine. The other formulation of cabotegravir is the one that was used in the study, is a nanosuspension that has a half-life of between 20 and 40 days. Rilpivirine, as many of you may know, is an FDA-approved non-nucleoside reverse transcriptase inhibitor that is currently available as an oral agent. This study used a nanosuspension long-acting formulation with a half-life of 30 to 90 days. And what this study did was it was intended to look at the safety and efficacy of this combination of these 2 new nanosuspension formulations for maintenance antiretroviral therapy and to select a dose for further study. It was a multi-center randomized open-label phase 2 study that had an oral induction phase with other drugs and then a parenteral maintenance phase. It enrolled adults who had not previously received antiretroviral therapy and who had CD4 counts above 200. I'm going to show each study that I'm going to look at is going to have a similar kind of structure. So it's a little complicated, but it was the best way I could figure out how to illustrate what happened in this study. So it took individuals and the patients, they enrolled 309 patients in this study. Most were male, most were white. They had detectable viral load and were just initiating therapy at a quite high CD4 count, which is really pretty typical of patients nowadays. They received an oral cabotegravir plus abacavir 3TC regimen. And for those who then were virologically suppressed at the end of this induction phase, they were then randomized to one of three arms. Individuals who did have virologic suppression at the end of this phase also received 4 weeks of oral rilpivirine as a safety test because they did not want to give a long-acting formulation of rilpivirine to people who had never seen it before. There were 2 parenteral arms, one that provided injections every 4 weeks, one that provided injections every 8 weeks, and some individuals continued on the oral regimen. The study is an ongoing study. The data that I'm going to present, that were presented, are at 32 weeks, and this is not it's clear that my diagram's not to scale. 289 of the 309 patients entered the maintenance phase as a result of having virologic suppression, and the group said they were representative of all those who'd entered the study. And their primary endpoint was virologic suppression less than 50 by an algorithm that's well known to HIV investigators called the FDA snapshot analysis, which just refers to how they analyze the data. And this is not a pretty diagram, but it does show the results. You can look online actually and see Latte 1 beautiful pictures from the publication. There are not such beautiful pictures available in the public domain for Latte 2 yet. So this is my attempt to get, but what you can see is there was prompt, excellent virologic suppression, and it was maintained in all 3 of the arms of this study at a high level without differences. There was about a 1% difference between the arms at their primary endpoint. There were a number of injection site reactions. In fact, over half the injections that were given in the study resulted in some kind of an injection site reaction. However, the majority of them were mild, and the median duration of the injection site reactions overall was 3 days. There was no difference in rates, grades, or duration between the 2 parenteral arms. And interestingly, the report of injection site reactions decreased over time from the first day to the last week of the study. Whether this is a real decrease or just a reporting fatigue or somebody getting used to the side effects is unable to be determined. But what was, I thought, even more interesting was they did a patient questionnaire toward the end of the study, and 98% of individuals in the injection arms were very satisfied and willing to continue on their current arm, whereas only 71% in the oral arm felt that way. Admittedly, this is probably a biased sample by those who are willing to go into a study that has parenteral therapy, but I think it's still quite interesting given that this was 2 quite large injections in the buttocks, either 4 or 8 weeks for several months. The toxicity outcomes were really not particularly remarkable. I think the most important piece was that for the new grade 3 or 4, which means moderate to severe, side effects in the maintenance phase were quite similar. The rates were quite similar in all 3 of the arms. So bottom line, this study suggests high rates of success in both arms, high satisfaction there, and the potential in the future for some kind of novel regimen. The next study that I wanted to mention is the study looking at a new formulation of tenofovir. And the important point of this is that this is a combination that is going to be approved and likely to be available widely within a few months. So this is a TAF, is a novel prodrug of tenofovir. It gets much lower plasma levels, although similar intracellular levels to tenofovir. They have been previous studies of this drug in combination with elvitegravir, but the novel thing about this study was that it was looking at the use of this combination in individuals who were on a different third drug. So once again, multi-center randomized double-blind adults on, this time with HIV, on successful regimens that included tenofovir and FTC, who were virologically suppressed. And these individuals then were randomized either to a TAF, a switch of their tenofovir FTC to TAF, or maintaining the same complete regimen About half the individuals, their drugs were in a boosted PI, and about half were in unboosted drug, most notably NNRTIs or integrase inhibitors. The characteristics were balanced between these groups, mostly male, mostly white, with viral suppression and a high CD4 count, as you would expect. The study's another one that is ongoing. The data for this study are looking at 48 weeks. And bottom line, there really was excellent virologic suppression that was maintained in both arms without particularly differences by subgroups that were looked at. And clearly this suggests that the TAF formulation was non-inferior virologically. There were a variety of adverse events, but no predominant adverse event, no major differences in toxicity, frequency, grades of toxicities with this new formulation. The only thing, in terms of laboratory data, lipids tended to stay better with the tenofovir, but we do know that tenofovir has a lipid-lowering effect. There were also some biomarker data with respect to statistically significant but very small improvements in urine biomarkers in various protein to creatinine ratios, and very small but statistically significant improvements in the group moving to TAF in terms of bone mineral density. So bottom line, looks like this is virologically a non-inferior, and the adverse events were generally similar, although there were some biomarker data which probably we don't really know the clinical significance about that improved with the switch to TAF. And the important thing to know is that this is going to become available. Some very sophisticated patients are already asking about it. There are some triple fixed drug combinations with this formulation that are under development, but the only ones that will be available are the one with integrase inhibitor alvitegravir and then this new double drug formulation. Then lastly, we're going to talk briefly about the challenges of substance users who have HIV. And anyone who's ever taken care of someone who uses substances is well aware that these individuals have challenges with many kinds of medical care. And when they have concurrent HIV, they have associated decreased rate of virologic suppression and faster disease progression. Where you can find them is in the hospital, and that's the information that this team used to develop their study, which was to test the effect of a structured patient navigation intervention and contingency management structure on rates of virologic suppression. This was a multi-center randomized study of these two behavioral interventions in HIV-infected active substance abusers who'd been recently hospitalized. It was a mix of opioid, stimulant, and heavy alcohol users, and the major criterion was that they did not have virologic suppression. This was done in 11 hospitals who had a lot of experience with hospitalized patients with HIV in the recent past. The structured patient navigator intervention was 11 sessions that included motivational interview and trying to link individuals to care. And the contingency management was graded financial incentives for specific outcomes, with a maximum of over $1,000 if people took care of all their incentives. This, once again, was a randomized study to these three arms, 801 patients who had a lot of psychosocial challenges. The intervention lasted for 6 months, but the endpoint was at 12 months. And that really shows the challenge. There was pretty good adherence to both types of interventions. The number of visits to the HIV provider at 6 months was much better, but not at 12 months in the arms that had the intervention. And similarly, the virologic suppression rates at 6 months were better, but not better at 12 months. And there did look at what predicted virologic suppression. So the implications of this is you can potentially, with intensive interventions, increase linkage to care, but the effect doesn't persist, and we really have a long way to go in this patient population. So take-home points, there's good news for the majority of patients with HIV. However, there are a lot of people being left behind that need new strategies, and we really have a lot more work to do to help all of the patients with HIV have success with antiretroviral therapy. Thank you very much for your attention, and if you have questions, I'd be happy to answer them.